my great honor to start to get an overview of what people of AML Hub think of what results are really needed prior to therapy initiation for newly diagnosed AML. And I think we have prepared 2 slides to start the discussion. One is where we talk about what do we really need to know prior to primary induction therapy. And the other one then, of course, should also discuss, or we also should discuss, what is really needed if we go into transplant in first complete remission. And to start with the later one, I think we already heard about the upcoming abstract at ASCO that talks about MRD as a tool prior to transplant. Then, of course, we also could discuss how to best identify patients that are really suitable for transplant. There we are also like moving up the border with regard to patient age, for example. And then, of course, one could also discuss how all these parameters can be applied globally. And with regard to primary induction therapy, of course, the history of a patient does matter with regard to high-risk leukemias linked to MDS or therapy-related AML. Then, of course, we all are aware how cytogenetics and molecular genetics influence treatment decisions. And here I would like to get a view of what you think is the most important information on how we should move forward with that regard in the future. And then, of course, here also it is very important to see who is fit or not fit for intensive chemotherapy, especially as we now have more treatment options for unfit patients. So how should we best discuss or start the discussion? What do people think with regard to the importance of the previous history of a patient? Perhaps I ask individual colleagues, or do you raise your hand to start the discussion?
I think go ahead and call on people and then as hands raised, because otherwise we won't know what to do.
Yeah, so Brian is the first one. Yeah.
Thanks, Lars. I'll get you back for that. Yeah, I think it is. I think it is important because, I mean, I think we're getting an understanding of some of the genetics that will follow these antecedent effects, whether that's a preceding blood disorder or previous treatment, but they're not an absolute indication. So I think a history does matter because it will give you some information where more objective measures such as genetics won't always. So I certainly make sure I always ask my patients that.
Yeah, you make a very important point that, I mean, of course, very often these diseases are linked to unfavorable markers like P53, ASXL1. But the other day, we also had a patient with a previous, with a therapy-related AML who had a normal karyotype, no P53 mutation, and nevertheless, he was refractory to induction therapy with CPX351 even. So they are definitely high-risk patients. So with regard to the MDS perspective, perhaps Uwe, are you still around? Uwe, you can comment.
Lars, I'm always around.
I know that.
Yeah, MDS perspective. So what's the precise question to me?
With regard to the importance of a previous history of MDS, does that really matter in how we should induce the patients? Especially then also if they have been pre-treated, for example, with demethylating agents, and you would then have a patient who is borderline fit versus unfit, would you then rather proceed with venetoclax and azacitidine or try to do an intensive induction?
I think it's a question which is cannot be answered by randomized trials or by a lot of evidence. I think it's very important to acknowledge first whether the patient is in general a candidate for allotransplantation, and if so, what the likelihood would be to basically achieve a complete remission or at least a response with induction chemotherapy. So I think it's a case-by-case decision, and also biomarkers molecular markers, I think, may help to differentiate. But I think this is a little bit the challenge we are facing now in our clinical practice at the moment, and sometimes not easy to decide.
Yeah, I fully agree. Gail, you also want to comment on that part, or you think we should move forward?
I was actually going to comment on what you have in the title, Lars, because I think that captures a lot of people's attention, the word prior. And okay. I was going to just throw for discussion that I think on a a clinician in clinic basis, a lot of times that question is asked in these types of discussions, that what do you actually have to sit and wait for? So if you take the question or the title literally and say, what results do you need prior, then it becomes the question of, well, what are you actually willing to wait for, and how long are you going to wait for it, which I think is an interesting topic. And I think it gets back to what was said, that you have to make a general assessment of, well, what actually is this patient eligible for, irrespective of the data that are coming in. What are you thinking? And then, for example, if you've made a decision that you're going to go forward with a non-intensive induction, then the question becomes, based on where you are, how long does a cytogenetics or a PCR or molecular data, how long does that take? And does it matter anyway? Because if your initial plan is going to be start on an HMA venetoclax type of regimen, how is that going to change your management? So I just think it's worth a second of people's reaction, that the clinical discussion of what are you going to wait for, in my mind, is the patient exploding in front of you? Do you have a high white count and a sick patient and high fevers and pneumonia, and you've got to move, and it doesn't really matter what the cytogenetics and so forth come back, you have to do something? Or similarly, if you have a patient who's getting a non-intensive induction, no matter what, what do you actually have to wait for? And do the rest of the data really influence the post-induction management more than what you're actually opening with?
Yeah, very good point, that we should focus the discussion on that part, what's really needed prior to the start of therapy. I agree. But then, to summarize from what we have discussed so far, we definitely agree that the history matters. We have time to get it, also what previous treatment was given. Then with regard to the molecular markers, I think also I mean, there's very few reasons where you have to start immediately, where you cannot control the disease with, for example, hydroxyurea. So I would strongly also vote to wait for cytogenetics and molecular genetics, or at least if you cannot get cytogenetics quickly, that we should do, like, let's say, low coverage whole genome sequencing to get the copy number. Does anyone want to comment on that? Selina, perhaps, or Jorge?
So our approach is that we immediately, in 4 hours, get obviously poor APL results and poor binding factor. And if the patient has is a potential candidate for Vyxeos, we immediately do FISH for 5, 7, and 17. So we have that all back within 24 hours. And then we send off FLT3 and have that back while the patient is getting induction. The rest we don't feel is needed prior to, but we feel has to be drawn prior to, so that we have the information later.
Yeah, that's also a very good point, that some markers you need immediately, but the others definitely have to go on their way prior to the treatment start. Jorge, I think you were next.
Yes. Well, coming back to the prior antecedents of hematological disorders or therapy, I think that if we are able to get back the full cytogenetics and molecular profile on time, this is gonna be most important than in that case this clinical history. And the decision of giving one conventional chemo or hypomethylating plus venetoclax or CPX is going to be more based on the results of genetics and the fitness of the patient and the potential toxicity than to the prior antecedents. So if we keep that in as relevant at the moment, this is going to disappear when we will be able to have all the molecular and cytogenetic profile in less than 10 days, including NGS.
Mm-hmm. Yeah, I agree that I think this is where the field will move to, that we get this full coverage work up with the new technologies in a fast time. And then I think it would be wishful to have it, of course, before we start. But I think for the markers that immediately influence your treatment decisions, like the ones that Selina nicely summarized, those are definitely the ones which we already now need already prior to start. Eduardo or Jeff? I'm not sure who was first.
I think Jeff was first.
Okay.
Yeah, that's fine. Just getting off the track a little bit of the scientific component. It kind of goes without saying, but I think should be included in sort of the results section before primary induction, would be that, you know, we're in an era where we have so many available options that it's important to really understand the patient's situation going into the treatment, and not necessarily related to comorbidities, but their choice as it pertains to, are they able to receive outpatient-based therapy without, you know, an adequate support system in place. It's not easy to do HMA venetoclax in the community in many cases for logistical reasons. And those patients may be more appropriate for induction therapy, I found, and vice versa. There may be patients who are well enough and fit enough to go through induction, but would prefer to be on the outpatient side of things for a variety of issues that, you know, we can't automatically assume we know just based on their a one-time visit or the biology of the disease. So I just think it's important to make sure we include that as a bullet point in the decision-making process, because we do have choices. And in some cases, for example, you may not need as much information if a patient is automatically going to be moving into, say, an HMA venetoclax type of a role, if that's what they've decided based on their needs. So I just want to make sure we have that kind of in the realm of discussion, because it is important. I think it's becoming increasingly important as patients become empowered to make decisions. Thanks.
Yeah, that's a very valuable point, which we should perhaps then also fits not only fit for versus unfit for intensive chemotherapies, but also then, of course, what is doable or what is manageable in the patient, and what's the patient's wish. Yeah, that also determines. Yeah, it's a very good point. Yeah, Eduardo.
Yeah, a couple of points concerning the history. I think we need to raise awareness about germline mutations as well. So it's sometimes difficult to find this kind of information when you reveal the charts. So of course, I don't think this is a must prior to therapy, but I think it's history. So I think it would be important to raise awareness about that.
A very important point. That I think we could move that over to the other part, to the transplant. I mean, definitely could be a must prior to allogeneic transplant, especially if you think then of the donor selection, right?
Yeah, no, I totally agree. I think that, but usually you can get this right from the first interview of the patient. So, and concerning the cytogenetics and molecular genetics, we have here in Brazil, we have an approach that's similar to what Selina has described. Of course, I would like also to highlight that the anti-PML immunofluorescence test is very useful for identifying APL cases, especially when you are in community settings. So I think this should not be forgotten. And we don't get results in 24 hours. So we usually are comfortable in accepting results up to 5 days or even a week. With very few patients that are, as Gail said, exploding, then you have to take some action. But I personally think that 5 days to a week, it's okay for us.
Yeah, it's an important point. I mean, there was a nice paper published by the Study Alliance Leukemia group that showed that if you manage the leukemia well with hydroxyurea and supportive care, the time to induction therapy does not influence outcome. So you can wait for one week up to 10 days even, and it will not have a negative impact on the treatment outcome. So you definitely can wait for the relevant markers. But I think
I want to push back on that just for 1 second, if I can, because I think that I have watched this sort of in the last 15 years flip back and forth. That so yes, there's no doubt about it that you can wait, but I push back on whether you should. Because I do think that when you have accumulated some information about the patient, the situation, the plan, and so forth, I try to push my team to really ask the question, all right, are you going to change your mind with these results or not? And to put your nickel down a little bit, that what are you waiting for? Not just the 250 genes that come back, because now I have 250 genes, 249 of which I don't know what to do with. But what are you actually going to do? Because I do actually find that while I am not jumpy and there is no rush, and we know this and the data are supportive, I think that from a mental anxiety perspective, sometime for the patient and the family to be sitting around and waiting or not knowing what exactly you're going to do, I do think that that potentially also has consequences. And I just want to make sure that the message in my mind, the clinicians, that they should understand, if you really are going to change, if you know in your mind that I'm going to do X if this comes back and Y if that comes back, fine. But to have that sort of intellectual commitment, that are you just waiting because you can, or are you actually going to do something different?
Yeah, I agree, Gail, with that opinion. But in case when you have clinical studies ongoing with certain mutations, I think you have to wait for the outcome. And Lars, we mentioned, I think, nearly everything what is needed prior to therapy. But we should not forget for the younger patients that we should discuss whether there is an oocyte or sperm cryopreservation wish in that patient.
Yeah, very important point. I mean, that's not needed for starting the therapy, but that's definitely needed if you want to live a normal life afterwards. Again, yeah, it's an important point. Yeah, we could add it here definitely, that you do not forget about that. And Andrew, you want to join into the discussion as well with regard to that point?
Yeah, I do agree that from a practical point of view, if you have a clinical trial which requires, target stratification, then, we do have to wait. If you don't have a trial, then really, apart from the cytogenetics or morphology to exclude APL, pretty much it's either you're going intensive or you're going non-intensive. And these days with non-intensive, I guess in the US as of May 25th, it's whether you're going to use an IDH1 inhibitor or not. And so that might be required, and that's going to be an HRM or some rapid turnaround assay if the place doesn't have, whole genome sequencing available within 48 hours, as you might. And FLT3, we don't have to start that till day 8, so we don't even need that on before starting therapy. So I guess from a practical point of view, we don't need a lot of information to get going. I always try to emphasize to hospitals outside to just store some RNA at the beginning, because it's really hard to do MRD. It's not impossible, but it's always nice to have a baseline sample. And if it's not done routinely, doing it as an afterthought is always going to lead to some patients, not having that available.
Yes, also a very good important point you make here. Perhaps we can split it and say what would be optimal to have or ideal to have, especially if you want to include patients into trials, and what should be definitely be there in a, let's say on a daily routine practical setting, or let's say if you're in a country that does not have access to all the new technologies basis. And I think there we can live with less. And I also like the thinking of Gail saying that I mean, if you are waiting for something that really will change your decision, then you should wait for it. And if the factors which you think might be needed will make a treatment or change the treatment anyway, then I mean, yeah, you can start right away. I completely agree.
One thing I might
but for example, for me, a case like that would be, let's say, an older patient where you are not sure, fit, unfit. I mean, where you struggle whether she should get intensive therapy or not. And then, for example, if P53 would be mutant, I would rather move forward with CPX351 if that's acceptable, as I know that, for example, venetoclax and azacitidine is not working that well. But if that would be negative P53 or no complex karyotype, then perhaps I would
I think he might be having
forward with the therapy. It's a matter of the patient would vote against intensive.
Just cutting out.
Lars, I think your internet is in and out. Perhaps if you turn off the camera, you'll have a stronger voice connection. I think he's cutting in and out, so maybe I'll just jump in while he sorts out the internet. He's in a faraway land somewhere. Andrew, though, I think you wanted to make a comment.
Yeah, I'd be interested in people's opinions, because this isn't a topic which I do struggle with, and that is the cytogenetics comes back, it's complex or it's monosomal, and then let's say you could get the mutation testing back and it's a biallelic or a high VAF P53 variant and the patient is 65 or thereabouts. It's not straightforward, I think, to know exactly what to do in that situation, because I don't think there's any great evidence that CPX is actually good or better than anything else for P53. We know that Ven/Aza is not improving survival either. Conventional chemotherapy, I mean, what do people do in that situation? It's not straightforward. I think if you don't have a trial, which is what the patient could go to. Gail, what would you do?
Yeah, I mean, I think that, I think candidly, the large data sets that were kind of coming out at ASH, and then at least one of them since published, looking specifically, diving into that CPX versus HMA-Ven question, right? Because that's really, which way do you go? You've got the person who could get either one. What are you going to do? And I think that there are a few statements that I think everybody more or less agrees with, which is that, well, you don't like to see a TP53. They're not all the same. So low VAF versus high VAF probably matters. Complex karyotype with versus without. All of these things, none of it's good. None of it's good news, but it does probably matter a little bit. And the bottom line is that if you don't have a clinical trial, which is what we all want for these patients, you are left with a rather boring decision of whether you feel like giving CPX or you feel like giving HMA-Ven. And that is going to rest in the majority of current cases on your institutional experience and preference and logistics with both. Candidly, I don't think anybody likes to give 7 and 3 in that scenario. I think there is perhaps a hair of an advantage, or at least that we think, with CPX, and Jeff can jump here too. But there are some institutions that don't even have CPX on formulary, so it doesn't come up. So you are making an unhappy decision of an HMA-Ven regimen or an intensive chemo regimen based on all of the things that would guide that decision otherwise. Where does the patient live? Can they handle it? Are there insurance considerations involved? Are there logistical considerations? And you're doing this with a reasonably heavy heart because you don't love either one. Jeff, I mean, from a CPX perspective, do you have more love in the complex karyotype TP53 situation than I am accurately portraying?
No, you represent my opinion very well. I have very little faith in anything, including CPX, in that setting. And I tended to look at it from the standpoint of, are we going to be able to treat a patient with curative intent, and that being a factor in deciding whether more intensive versus less intensive induction would be most appropriate, and usually siding towards less intensive therapy for patients who fit that criteria, complex karyotype P53, who are clearly not going to be treated with curative intent. But now with, maintenance therapy options in ONUREG, for example, you have potential life-extending therapies that could still warrant induction therapy in that setting. So it becomes even more complex. So I struggle with the same issues, but to your question, as far as choosing CPX in that setting, I tend to shy away from it and move more towards HMA-Ven if I feel that we can't move forward with a likelihood of remission followed by transplant.
And Dr. Miyazaki, I think, has a hand up.
Yes, I agree with Dr. Roberts, what say, and Andrew, and also Jeff. If we can get an information regarding a nice genetic mutation such as FLAT3, which has a drug to treat, that's going to be okay. But markers suggesting poor prognosis, it will not dramatically change the choice of induction therapy. Anyway, we have to deal with the leukemia burden, but we will change the consolidation or after those treatment strategy. So, of course, it largely depends on the information you can get depending on where you live and what kind of insurance you have. But the information from molecular genetics is not as large as we expected previously.
I think you bring up an excellent point that I would like to emphasize, and then I'm going to turn it back over to Lars to figure out what to do with the MRD, and also we want to just make sure that we get our sessions in order. But one point that was just made that I think is incredibly important is that perhaps, just food for thought, I think we all obsess over what we are initially giving the patient. And that's actually not the right moment to obsess over, perhaps, because you can get AML patients into remission with a lot of stuff these days. And I think we are all, oh, do we do this? Is it CPX? Is it you can pop an AML patient into remission fairly reliably, right? There is a 30% primary refractory disease that's going to happen no matter what. But I actually believe that it is what you just implied, that it's the post-remission. What you do next is actually the more excitingly confusing zone. I don't really care if the patient's 65 and looks okay and has AML, you're probably going to get them into remission with either intensive chemotherapy or HMA-Ven. And if you're not, you're not, and then you're going to try the other one, whichever one you didn't do first, you're going to try second. So it doesn't feel like rocket science, but maybe the post-remission therapy is where now there is a bit of confusion, because are you giving somebody HMA-Ven forever? Are you giving an oral hypomethylator? Are you doing a transplant, even if the patient is 79? That, I think, personally is more confusing. And now I can see and hear Lars, so I'm going to turn it back over to you.
Yeah, thanks. I'm sorry, internet was really gone, and using the phone is also not working here very well. So yeah, so I'm not sure how much time we have left and whether you have started. It looks like you haven't started the discussion on transplant at all. But thanks for your summary again, Gail, that I'm completely with you. that now with these more options being available, we really have to think about who we should transplant. And here I really think MRD can be helpful in a way as for example, the patients which are still MRD positive after intensive induction. I mean, even further intensification might not make them negative, and they might need a different approach. And with regard to the ones that are already MRD negative, perhaps we need less intensive protocols because we still will do good with the transplant. So what do people think here? Anyone wants to start the discussion here? Do we need MRD prior to initiation of therapy? There's not so many transplant guys around.
Well, Roland hates it when I do this to him, but I'm going to do this to him because his window is right next to mine, and he already has rage when I did this in the last meeting. But Roland, so the same thing is going to happen again, that we have a data drop in ASCO again saying that, well, now if you detect MRD to 1 × 10⁻23rd, it's still bad. We knew it was bad if you detected in 1 × 10⁻², -3, -4, and now we're down to 1 × 10⁻23. And when this originally started happening, everybody said, uh-oh, you better not do an allo transplant because now there's MRD, and you and others. And we said, no, that's wrong. It doesn't mean don't do a transplant. It just means worry about it. So now we're extra worried because we know that if you can detect something prior to a transplant, it's no good. So what do we tell people?
Yeah, no, I think that's exactly it. I mean, it's not good. And you know, sadly, especially now in the, so I was just reading Chris's abstract, and it's interesting that what he finds is really not what we see in our patients. And I wished I understood why that is, but it's very different from what we see, and I really don't understand it. But we are, as a transplant center right now, we're extremely stretched, and there's a burnout in providers, and they cut down on arrivals. And sadly, what I was told that the data from here would let people to not transplant MRD positive patients. That's exactly what we're doing here as well now. So we're looking at people with MRD and say, well, maybe we shouldn't transplant them because we have other people that might benefit more. I'm actually thinking that's sort of backwards because I think the relative benefit seems the same. But I think that's what's happening right now here. But I do think MRD is sort of helpful even for the decision potentially to choose a transplant or not. And this is probably where maybe that's the best data to decide who should get a transplant and who should not, as far as at least the favorable risk patients go. I'm not sure it helps you that much for other people. But we've sort of always prioritized myeloablative transplants, and that has remained unchanged, even with the sort of increasing understanding that MRD is really telling us something bad about what's going to happen later on.
I think from a German perspective, and if in the presence of MRD, we would not do the transplant. But I think what we would do in the clinical routine, apart outside from clinical trials, is we would of course do an increased surveillance after transplant with regards to MRD, because I mean there are also patients, if you can condition them with myeloablative conditioning, they may achieve MRD negativity even early after transplant. So then monitoring surveillance strategies I think are very important. Immunosuppression may be tapered more aggressively. Preemptive or prophylactic DLI may be also considered. I mean, these are outside clinical trials, I think, measures to maximize maybe the potential graft versus leukemia effect. It's not a guarantee that it may work, but at least from a German perspective, Roland, I think we would still transplant the patient, or if possible, do, for instance, in NPM1 mutated patients where still there's a high MRD load prior to transplant, may switch to aza-ven to lower this MRD load prior to transplant. I think these are the, let's say, tools in our hands outside any clinical trial intervention.
Yeah, thank you very much, Uwe. This is also how we would do it. So we would definitely try to get some GVHD in these patients. And we also would transplant them because, I mean, even though the outcome is worse, for many of them, that's the only chance of being cured. So Jordi, you were next, or Agnieszka?
Lars, let me just jump in because I'm watching the clock and I want to be mindful of everyone's schedule. I think that there were two other comments which we can make quickly, and then we'll make, we want to leave at least 10 minutes for the other discussion.
Yeah.
Well, really in this situation of MRD pre-transplant, we don't have any prospective data to answer that. But in our setting, we believe that it is not good to transplant patients who are MRD positive. So what we are trying to do is enroll these patients in clinical trials. Even we have a trial with venetoclax and azacitidine to treat this situation. And if the patient cannot be included in a clinical trial, then we try to give hypomethylating agents to see whether we can convert to MRD negative. And if this is not the case, then we proceed to the allogeneic transplant, also with early discontinuation of immunosuppression, and trying to administer, and this is my personal view, myeloablative conditioning.
Okay, thank you very much. Agnieszka, you also want to comment, or everything is covered?
A very brief comment. Just I would like to say that our approach is very close to this presented by Uwe. So we are still do not have any good offer for MRD positive patients. So we are trying to bridge them to allogeneic stem cell transplantation with the fast tapering of immunosuppression. And for some patients, we are using post-transplant maintenance with azacitidine or for FLT3 positive patients with sorafenib. Of course, I think the issue is also the role of post-transplant maintenance for MRD positive patients, and it could be a nice topic for further clinical trials. Thank you.
Yeah, thanks. Thanks to all of you for the discussion. But then to summarize that part, I think we all agree that MRD definitely is a helpful tool and influences many treatment decisions, either whether patients should be transplanted at all or how they are managed. So definitely worth to be looked at prior to transplant. And yeah, once again, thank you for the discussion and sorry for going over time.